Thank you very much. I'll just speak from here if that's all right. It's an honor to be invited to speak today. In just 10 minutes, I'll just hit some highlights regarding bariatric surgery. First, the definition of severe obesity has been used by many as the indications for bariatric surgery established by the 1991 NIH consortium, BMI greater than 40 or BMI greater than 35 with comorbidity. At the present time, we've seen an expansion of considerable investigation into the benefits of bariatric or metabolic surgery for less severe degrees of obesity, that is BMI greater than 30, among patients with type 2 diabetes. Dr. Jonowski, who I've had the honor of working with for the last 12 years in the LABS consortium, showed the weight loss that was demonstrated in the LABS consortium. It's clear that major weight loss among patients with severe obesity benefits health. The remission rate following gastric bypass of type 2 diabetes, 62% at year 3. At year 7, it's still 59%, so the remission of diabetes is durable. With gastric banding, the remission rate is lower, there's less weight loss, and there are special effects from gut manipulation that affect diabetes. Remission of other conditions, hypertension, dyslipidemia, sleep apnea, psychosocial impairment, functioning, employment status are all improved in the general population undergoing bariatric surgery. We'll hear a bit more of that later. There's also multiple studies with comparator groups that have been constructed, no randomized long-term clinical trials, but all the comparator groups, no matter how they've been constructed, have shown improved survival if weight loss is achieved by bariatric surgery. The issue that requires a further examination is, well, if there's all these great benefits from bariatric surgery with weight loss, what about complications? That is certainly a concern anytime major surgery is done. This is the data from the LABS consortium. We had 100% follow-up among about 5,000 subjects at 30 days. The mortality rate 0.3% for gastric bypass, 0.2 if it's done by laparoscopy, which is now 98% of how bariatric surgery is done. Serious complications occurred in about 4% of all patients, about 5% of gastric bypass. These data are about 10 years old now, and the complication rates from the national database show that the safety has, in fact, improved further. The mortality rate, in fact, has gone down by more than tenfold in the last 15 years. So those who believe that bariatric surgery is unsafe need to be updated regarding the latest data. This is a summary of how have we done that within surgery. We recognized that complications were problematic, and the surgical society set about examining why was the mortality rate 2% and what could be done about it. Much of that can be summarized in our Senator Accreditation program, which we now routinely use. There are 700 certified centers by the American College of Surgeons and the American Society for Metabolic and Bariatric Surgery. The components of an accredited center include requirements regarding the training and experience, laparoscopic training of the surgeons. This was one of the key factors initially. Data is recorded and submitted to a central registry where it is analyzed, risk-adjusted, and returned to the centers to serve as the basis for quality improvement projects, so that the performance of individual surgeons and centers is now carefully monitored and corrective action is taken if problems are identified. Furthermore, there are standardized protocols for care that have to do with patient selection, pre- and post-operative care, which have certainly had an impact on standardizing the outcomes. What about long-term complications? This is very much more difficult to study because the patients disperse off into the population. They do not return to the center where the surgery was done over a period of many years. So it's difficult to know exactly how common these complications are. We tried hard in the Labs Consortium to do so, even though we had contact with 92% of the patients at year 7. It was not feasible for us to determine exactly how common was iron deficiency anemia or other problem because, again, they go to their primary care provider who diagnose and treat the problem. But the most common nutrient deficiency is iron deficiency anemia. It's readily correctable. In some cases, requires parenteral iron. And it should be noted that there does not appear to be an adaptation over time to absorption of these micronutrients. So the risk of a micronutrient deficiency is ongoing over a period of many years. And the requirement for supplementation continues. Despite that, nutrient deficiencies leading to central or peripheral neuropathy, though rare, can occur and can be quite tragic when they do. The issue of bone metabolism over time is complex because we don't have a long-term control group, and about 80% of bariatric surgery is done in women who have a problem with osteoporosis and fractures as age advances. So whether in fact the bariatric surgery has a deleterious effect on bone is unclear. There are metabolic complications that can occur over time. Hypoglycemia is reactive postprandial for the most part. It is more common among subjects who did not have diabetes at the time of operation. Severe hypoglycemia is rare, but lesser degrees are relatively common. It's difficult to nail down exactly how common hypoglycemia is because most people are treated in the field for their symptoms before they ever get to an emergency department or healthcare intervention. Renal stones are more common among people with obesity. There's a concern that gastric bypass will increase the incidence of decreased renal function as well as increased stones. That data is not so clear. We do have data from labs now that those with impaired renal function at the time of operation, in fact, experience improvement in their renal function over time. Surgical complications also occur. Intestinal obstruction may require reoperation, as might marginal ulceration, abdominal pain, cholelithiasis, the most common. In the Labs Consortium, we've identified that about 13% of patients over 7 years required a reoperation of some sort, most commonly for ventral hernia at one of the incision sites. So it is not without complications, to be sure, but hopefully these are all manageable and do not represent a major problem. Behavioral psychological issues are important. Depression for the overall population responds well, as does quality of life, but there are certainly cases of depression that are not directly attributable to the obesity at the outset, and such that the depression may not routinely respond to weight loss. Suicide has been identified as somewhat increased following bariatric surgery. The numbers are very small, so it's difficult to analyze statistically, and there's increasing evidence that suicidal ideation, which is easier to study, in fact is prevalent among this population before they undergo bariatric surgery, and the incidence following bariatric surgery seems to be about the same. There's a major issue as to access to bariatric surgery and who undergoes surgery. This is a study of sociodemographic factors or predictors. We see that women are much more likely to undergo bariatric surgery. This issue is confounded by the fact that women are more likely to seek bariatric surgery. Insurance status is also an important issue. We see that for private insurance, the odds ratio of actually undergoing surgery is 2.5 times higher than it is among a population that is insured by public insurance. And in fact, in labs, 8% were Medicaid patients. By epidemiologic data, it should have been twice that. And what we know is that these are not the same population. The Medicaid patients were heavier, had more diabetes, and much more severe walking and other limitations. So there's a number of reasons why this might be. The reimbursement by public insurance is diminished, so the providers may not accept it. Just about less than 2% of patients who are eligible for bariatric surgery undergo such surgery in any given year. And it turns out, this is Dr. Aroney's slide, that the number getting treated with pharmacotherapy for obesity is similarly low in the range of 2%. So there's certainly room for improvement with regard to access and delivery of effective care for obesity. Thank you.